you being here today and for having me here. It's my absolute pleasure to be presenting at this excellent seminar series, an output from the HCAP, the Health Governance After Brexit project led by Professor Tamara Harvey in University of Sheffield. I'm based in Queens. And this paper is based on some unexpected outcomes of our street legal ethnography work for the project. It's still very much in a raw form, this paper. We're writing it at the moment, so feedback would be much appreciated. And I just want to let you know, in case you're wondering why my head is constantly pointing down, I'm just reading my notes here on my phone, in case you're wondering what this is about. Oh, I don't know if you can actually see the next slide. I hope you can. Please let me know if you can't.
That's fine.
Yeah. The plan for my presentation today is to introduce the premises and scope of our paper, to focus the discussion on the NHS long-term plan for England as a key policy document for post-Brexit health governance, to demonstrate how we use the critical concept of responsibilisation coined by Nicholas Rose to understand the long-term plan as a governmentality strategy of responsibilisation that could define the post-Brexit health governance period, at least in the UK, and to give a real-life dimension of responsibilisation by using data from our street legal ethnography. At the end, I will draw some conclusions on the potential success of the long-term plan as a responsibilisation strategy and the possibility of grassroots resistance to it. The long-term plan was published in January 2019 on the 17th birthday of the NHS. The main purpose of the document is to reflect on the importance of the NHS as a health institution and to tackle some long-standing criticisms and problems. The long-term plan emerged as a policy response to three big truths about health. One being pride in the health service's enduring success and the shared commitment that it represents. Another big truth is concern about funding, staffing, increasing inequalities and pressures from a growing aging population. And three, optimism about the possibilities for continuing medical advance and better outcomes of care. The three main policy commitments that the long-term plan makes are to make sure everyone gets the best start in life, to deliver world-class care for major health problems, and to support people to age well. These policy aims are to be delivered by a wide variety of steps, from enabling patients to have more control of the health and care that they receive, to tackling some of the most significant causes of ill health and health inequalities by increasing the NHS workforce, and by providing more convenient access to services and health information for patients. Interestingly as well, a major policy commitment within the long-term plan is to make better use of the NHS's combined buying power. Delivering the long-term plan was made part of the broader premises of post-Brexit governance in a speech made on the 25th of September 2019 in the House of Commons by the Prime Minister Boris Johnson. He declared that his government wants to put Brexit behind them and focus on the NHS by presenting what they call a program for health and life after Brexit. The Queen's speech that followed in October 2019, apologies for my voice breaking, referred to the long-term plan as the key policy focus for the period post-Brexit for the United Kingdom, promising that new laws will be taken forward to help implement the long-term plan in England. The new laws in question, we now know, are the proposed Health and Care Bill designed to accelerate the implementation of the long-term plan. While the long-term plan emerged against the background of Brexit and has been linked to the program for government in England at the moment, it is likely to inform debate on its organization elsewhere in the United Kingdom, including Northern Ireland, since the NHS is a devolved issue. This is why we use data from both England and Northern Ireland in our paper, despite the long-term plan being a document focusing on the NHS in England. Here I want to quickly take you through the theoretical framework we use for our paper, which is the work of Nicholas Rose on responsibilisation. Responsibilisation, in short, can be described as the shift from state responsibility for, let's say, health to individual responsibility in a marriage of both an ideological logic of what constitutes good governance and a strategy for the control of the behavior of governance subjects. Rose describes that responsibilisation happens through a collective logic of community coming into an alliance with the ethos of individual autonomy by focusing on choice, on personal responsibility, on control over one's fate, self-promotion, and self-government. Specifically in relation to health, Rose argues that responsibilisation strategies rest on a bed of moral considerations of how a welfare state has the capacity to erode personal responsibility for health and personal freedom, leading to undesired economic and political outcomes. Rose writes that hence the theme of responsibilisation became central to many policy reforms in the field of health. Reformers from a range of different positions argued for changes that would diminish dependency and increase instead autonomy, giving individuals more control and more choice. At the same time, however, crucially for responsibilisation, individuals are to be urged, even required, to take greater responsibility for their own health, welfare, and security of their own, also of their families, and not to rely on the state and its professional apparatus for their security, welfare, and health. So we take the concept of responsibilisation and we try to see the long-term plan as a policy document that may appear bland, fairly formalistic, fairly regular even for a health policy document, but we see something different in it. We see it as a responsibilisation strategy. A key focus for the long-term plan is the understanding that in its current form, the NHS is not functioning in an optimal way. And that diminishes the chances patients have to receive quite high quality care. To this end, the long-term plan boldly aims to accelerate the redesign of patient care to future-proof the NHS for decades ahead. The idea that the NHS is dysfunctional would give substance to claims that a profound change in policy and approach is needed. And one of the moves away from the model of the NHS being the primary provider of care to one that sees multiple actors sharing the responsibility to safeguard and strengthen the NHS, including individuals themselves. As the Programme for Health after Brexit, then the long-term plan aims to responsibilise UK or England patients by relying on concepts like health promotion, shared responsibility for health, health risk reduction, with a great emphasis on individual behaviour. You can see chapter 3 of the long-term plan in particular for that. Such references suggest that in the post-Brexit era, patients will be encouraged to become consumer citizens with a greater than ever access to social and community services, complementing the traditional health practices. As Rose has argued, this elevates the freedom to choose one health services to taking responsibility for an uncertain future with limited ability to alter the outcomes. The long-term plan operates as a responsibilization strategy by expecting patients to be actively involved in the government of their health, by taking full advantage of social prescribing and the growing list of out-of-hospital services and care that they can receive. This has been referred to as a technology of freedom, governing through the freedom to make choices about one's health within the confined limits of this being an imperative rather than a suggestion. Individuals should be contributing to the shared responsibility for health creation by taking responsibility for their own unhealthy behavior. This aspect of the policy is reminiscent of the new liberal view of citizens being autonomous, rational actors with personal responsibility for health. The long-term plan makes subtle demand on patients to take responsibility for their health, to tackle unhealthy behaviors such as smoking, obesity, diabetes, diet, etc. Here, the economy of health is married to an ethical obligation placed on individuals to reduce their impact on the NHS by taking steps to not become patients in the first place. The long-term plan is subtle and subdued. As nowhere in the document, it is implied that those with unhealthy lifestyle would be denied health services. But the implication is that healthy lifestyle and targeting unhealthy behavior as it arises are key to the success of the long-term plan as the health governance strategy in the post-Brexit era. After having described how the long-term plan operates as a responsibilization strategy, and I'm certainly happy to elaborate on this if people would like me to in the questions and answer session, we further argue that the long-term plan and its implementation may not be entirely successful in responsibilizing patients, nor may it be readily accepted and internalized by the people it targets. To advance this part of our argument, withdraw on ethnographic data gathered through more than 400 informal street conversations that we collectively called street legal ethnography. Whilst collecting our data, we didn't expect necessarily the multiple narratives on self-responsibilization or participants in the conversation responding to the Brexit-induced anxiety with an increased focus on personal responsibility for health. But we certainly recorded them, and now we're using them to make an argument. Our data suggests that narratives on responsibilization are often accompanied by concerns about the NHS and the future of the NHS post-Brexit. This suggests that some people may be opening themselves to responsibilization and accept an ever-growing personal responsibility for health, indeed acting like consumer patients or responsible patients. But our data also sheds light on many frustrated individuals with no great confidence in the NHS who are creating contingency plans based on increasing personal responsibility. Other participants in our conversations, however, appear to be resisting the responsibilization narrative that we argue may be a key as well to the post-Brexit health governance future. So I've broadly divided our participants in those opening themselves to responsibilization and those who seem to be resisting to it. So I'll start with those who seem to be opening themselves to responsibilization. Narratives suggesting opening to responsibilization are never shared directly, but are expressed through other themes on the NHS and Brexit. Therefore, the data we have recorded is rich and often contradictory, meaning that one participant may express in one conversation's opinions pertinent to responsibilizations which are diametrically opposed. Yet we have managed to discern 4 themes around which opening to responsibilization happens. And these 4 themes are health being a personal responsibility as much as a state responsibility, responsibilization in the form of a contingency plan for the uncertain post-Brexit future, irresponsible behavior associated with health being critiqued as the burden on the health system, and narratives cognizant of the Brexit motto and theme of taking back control. So I just wanted to discuss with you examples from the data and exactly what was it that we collected. Examples of individuals assuming personal responsibility for their health because they see themselves as central to the health management. That's basically the first theme. Include conversations where participants express an opinion that we are responsible for our health as much as the government is. Some participants that we spoke to appeared certain that health is first a personal responsibility and then an institutional one, if ever, regardless of Brexit. More nuanced examples of responsibilization included a perceived lack of authority of the state to look after people's health, as the government is only tackling health as a piecemeal operation. Responsibilization is a new liberal governance strategy for health, encourages entrepreneurial and prudential behavior, optimizing one's chance of receiving the best possible health care. And we have recorded conversations where people are talking about what is best for them, for their health, openly talking about going towards private healthcare. And this narrative is in tune with the long-term plan as a responsibilization strategy that also relies on opening health and the NHS towards competition and market-led models of governance. We also recorded narratives where self-responsibilization was happening as a contingency plan to a perceived dysfunctionality of the NHS. We spoke to participants who told us about their very negative attitudes towards the NHS that would compel them to open themselves to regulating their behavior towards more healthy life choices, for example. Some participants made the connection between the perceived failing of the NHS and that necessitating an orientation towards a more personal control on the individual level, where these conversations depart from the long-term plan, which overall aim is to empower patients to act more as prudential consumers of health services. Far from presenting empowered and confident patients, our data suggests that there is a heightened feeling of self-responsibilization as the contingency plan, basically reacting to problems with the NHS. Some of the conversations we collected appeared open and very much responsive to the idea that other people's behavior must be regulated, not just you regulating your own behavior. And we've recorded conversations that open up interesting avenues for thought about what constitutes a responsible patient. In short, if I can summarize that very rich data, is a responsible or an ideal patient is one that has as little an impact on the NHS as possible in terms of taking advantage, certainly contributing more to the NHS than taking away. Some participants demonstrated such openness to regulating the behavior of others by suggesting additional charges being attached to the NHS for missed prescriptions or missed appointments, and tackling the concept of health tourism and, benefits fraud. And lastly, but by no means least, there were conversations we recorded that are very much in tune with the whole taking back control narrative of Brexit. Some people actually voted for Brexit because they believe, for example, the slogan on the Brexit bus, that more money would go into the NHS. So Brexit was very much about both the government and individuals being allowed to take more control and responsibility for the NHS. I keep thinking it's going to work with the button. Of course, we, as I said, we recorded conversations where there appeared to be a grassroots resistance to narratives of responsibilization. Conversations that challenge the realities or the insistence on regulating individual behavior were recorded in all of our fieldwork locations, both in Northern Ireland and in the north of England. And although, again, the data is very rich, it's very contradictory at times, we managed to discern 4 themes around which responsibilization resistance happens. One of them is a fear that the future spells privatization for the NHS. So people capsulating around the idea of protecting the traditional view on the NHS as a community service. A high level of distrust in the government. I'll explain how this is relevant. Invoking narratives on traditional pride in the NHS being, you know, the pearl in the UK crown and the envy of the world. And absolutely direct rejections of a constructed idea of what it means to be a responsible patient. So let me show you a few examples from the data again. A key theme in these conversations was the fear that the future spells privatization for the NHS. We understand this to be very different from the long-term plan's promise to save the NHS as such. Not only does the post-Brexit programme for health promise more funding for the NHS, but it also aims to improve people's confidence and empower them to be the drivers of their health by visiting the new and improved NHS. In this instance, responsibility seems to be an impossible goal, and the long-term plan as a responsibilization might fail. There simply isn't that much confidence or empowerment as far as our data is concerned. The resistance of the responsibilization narratives has been intertwined with a high level of distrust in government and in the NHS bureaucracy as well. The lack of trust in the government is part of the resistance narrative to responsibilization because the long-term plan as a responsibilization strategy is predicating upon the desirability of taking back control and ensuring one's own health is one's own priority. Some of the conversations seem to be rejecting the responsibilization process within the welfare state reform. This is an important point to make, we think, because parallels can be drawn between the sentiment of the welfare reform, for example, 2010, 2015, saving the UK from a complacent benefits grandeur mass of people, and the sentiment of Brexit, which is saving the UK and the NHS from a complacent and abusive EU system. There are also direct rejections of the constructed idea of what it means to be a responsible patient. Quite a few remarkable conversations, really. For example, a Rotherham participant listing the things that the government tells you are unhealthy: smoking, drinking, red meat, and basically arguing our fathers and mothers survived all of this. So in a remarkable way, rejecting the very idea of what it means to be responsible as a patient. I think I might be running out of time, so I'll just move to the conclusions here. With this paper, we aimed to give a real life dimension to theoretical, academic, philosophical narratives of responsibilization by juxtaposing them to some of the conversations we recorded in our street legal ethnography. We have aimed to show how we can use the critical concept of responsibilization to understand the long-term plan as the responsibilization strategy. There will be a key theme, we argue, in the post-Brexit health governance in this vacuum of legal and policy clarity on what the future of the NHS will be and what our experience as patients will be. People are filling in that vacuum with their own narratives, and data like ours suggests that responsibilization is a complex concept. It's either accepted or rejected at the grassroots level in multiple ways. People intertwining these narratives with other concerns and issues they have with the NHS and with the idea of what it means to be a responsible or an ideal patient. And we think that there is merit to explore these themes in relation to post-Brexit health governance and offer a different story about what it might look like. So that's me.
Okay, thank you very much, Ivanka. I'll just stop the recording.